Good
That's right.
afternoon, everyone, or good morning for some, depending on where you're joining us from. I do see some of you guys from Taiwan. My name is Iftamit, and I'm one of the board members of the Hospital and Home Society Australasia. I would like to begin by acknowledging the traditional owners of the lands in which we're all joining from online today, each from our own homes or workplace. For me, this is the land of the Wurundjeri people of the Kulin Nation, and I pay my respects to the elders, past and present. I also extend that respect to any Aboriginals and Torres Strait Islanders people joining us today. For today's presentation, we're joined today by Dr. Natalie Bransgrove, a registered nurse with a Master of Public Health and a recent PhD from the Federation University of Australia. Natalie has recently completed a PhD focused specifically on the hospital in the home, examining how older age and rurality shape access to HITH services in Victoria. This is an achievement worth recognizing. There are still very few researchers in Australia who have completed doctoral work dedicated to HITH, and Natalie is joining a small but growing group helping to build a stronger evidence-based foundation for our speciality. In today's session, Natalie will take us through what the evidence is telling us about HITH for older people, why model choice matters for equity and service design, and what this means for policy, funding, and the next phase of HITH research in Australia. As always, I encourage you to use the chat function throughout the session to share questions, reflections, or comments. These discussions are a big part of what makes the Grand Round so valuable. I'd also like to thank everyone involved in making today's possible. Our presenters for the generosity in sharing their work, all of you for taking the time to join us, and the members of the HITH Society whose support allows us to continue running these sessions. If you're not yet a member of the HITH Society, Australasia, I'd encourage you to consider joining. Membership helps support education, research, and collaboration across the HITH community. Finally, just a reminder that the views expressed today are those of our speakers and do not necessarily reflect the official position of the HITH in the Hospital in the Home Society Australasia. Any views I shared today are my own. With that, let's get started. Over to you, Natalie.
Thank you so much, Ifta, and thank you everybody for joining me. I'm just going to share my presentation so that you're not just seeing my floating head while we chat today. I would like to acknowledge that I am also presenting my views and the views of my research from what I've found, and not necessarily the views of the HITH Society or Federation University Australia. So, a couple of things. Not yet a doctor, very soon to be doctor, but Ifta is very excited for me to get that across the line. But yes, any day now. So happy, happy days. I'm going to be presenting to you today about hospital in the home for older people in rural communities. And I'm presenting on Gunai-Kurnai lands today. In line with my research, I am presenting in a rural area, so my internet is not very reliable, so please stick with me if the transitions are a little slow. If I do start getting really choppy, please let me know. I will turn the camera off and we can make that work, okay? So as you would have seen in the description for today, these are the things I'm going to go through. Really, my research focuses on older rural people and it is very Australia focused, but I believe that the findings can be applied internationally in the rural context, obviously just acknowledging that heterogeneity of different rural populations. And I hope at the end that you will walk away with practical things to help improve HITH in your areas, specifically for older rural people. So let's start off with what we already know. So when we looked into the literature at HITH for older people, we looked at it really broadly and we wanted to know, does HITH work for older people? Yes or no? Really simply. We found that there were some mixed results. And in fact, when we looked at adverse events, sometimes they increased, sometimes they decreased. When we looked at length of stay, same thing, a little bit inconsistent. When we looked at treatment failure, so that would be people who are returning to the hospital while still admitted to HITH. Again, there was a bit of inconsistency. But when we looked at patient satisfaction, carer satisfaction, mortality, and readmission, it was very clear HITH was beneficial. So we dug a little bit deeper and went, okay, well, why is there this inconsistency for some older people and not others? And we found that it is how they are admitted to the service that determines their outcomes. So those patients who are transfer admission, meaning that they are in hospital for a couple of days on the wards and then they go into hospital in the home, they actually had poorer healthcare outcomes than those patients who were directly admitted to HITH, meaning those patients that either completely bypassed the hospital and were admitted from the community, or those that were admitted directly to HITH from the emergency department, so never were actually in a hospital ward or bed. And this finding, while it was new, wasn't really that surprising because we know that older people don't flourish when they're in hospital. We know that they're more likely to obtain infections, delirium, and have falls because of those environmental changes. Oh, Ifta, we've got some people who can't see anything.
Yes, so what we might do,
Do you want me
Natalie,
to just
I
pause for a
will
jiffy?
pause for just 1 second
Yeah, of
and I will
course.
be the one sharing your amazing presentation. Give
Happy
me just
days, Ifta.
one
Let me stop sharing.
moment.
Thanks, guys, for letting us know. It's not going to be a very good presentation if you can't see. Happy days.
Give me one moment to just
Yeah,
try
of course,
and bring
Ifta.
it up again. And again, I do apologize for everyone.
Sorry, everybody. I will keep chatting in the interest of time. I just don't want to. I know everyone's got very busy lives. So essentially, we found out that the admission pathway actually made a really big difference, which we're not overly surprised by, given that, yeah, as I said, older people don't do well in hospital. And so because of that environmental element, we thought it would be a good idea to look at another environmental element, which is rurality. I'm a couple slides ahead of that, I think, lovely Iftar.
No worries. You tell me when to stop. So right now we're in HIT for older people, in which we got
Give me
increased length of
give me a couple of clicks. Yeah. Beautiful. Couple more for me, Iftar. I'll keep
couple
admitting people while
more.
you do that. We're multitasking. Why not?
Are we next to slide or are we still on this one?
We've got one more. Lovely. And then after this loads, we're going to do one more again. So that's where I want to be. Thank you, Iftar. So once we looked at the rural element, we found that we actually knew nothing about HITH for older people in a rural context. We didn't know what happened with their adverse events. We didn't know whether it increased or decreased their length of stay. We really didn't know anything about their patient outcomes. And we didn't know anything at all, not even dependent on their admission criteria or their admission pathway or their model of care. We just knew absolutely nothing. And so that's where my PhD came into it. Can I get the next slide, please, Ifta? Thank you so much. So what we did first was we did a systematic review to go, okay, well, what's happening with older people Australia-wide? And then I'm going to also present to you what I learned in a rural community. So next slide, please, Ifta. So first up, I'm going to talk to you about the barriers. So these were the things that in the literature was already known for older people in acute services like hospital in the home. We knew that at times there was inefficiencies, as we'd previously discussed. So that might be differences in adverse events or length of stay. And that was very closely linked with the admission pathways, those transferred admissions. The other thing was patient demographics actually was determined to be a barrier. So older age, people in research reported that if people were older, they were less likely to be admitted, and those in rural areas were also less likely to be put onto the service. There were concerns about carer availability and workload, especially concerns about carer burden in the literature, and also about whether people were actually suitable. And his suitability was really closely linked with older age. A lot of researchers said, well, they're over 65, so they're probably not suitable. Therefore, we didn't put them onto HITH, or we didn't include them in our research at all. And also just health professional availability and understanding. Next slide, please, Ifta. And so then when we did our research, we went and we spoke to health professionals, patients and carers in a rural health service in Victoria to understand within their specific rural context, what was HITH like? And we learnt the same thing. There were some inefficiencies. However, these were quite different. We found that these were mostly related to policies and processes that meant that the process itself into being admitted to HITH was quite clunky and didn't work very well. Regarding patient demographics, it was more around the rural element than the age element. While health professionals didn't really consider age to be a problem, they also acknowledged that they probably didn't even think about HIT the minute somebody was 65 or over. The health professionals had a lot of misunderstanding about what HIT was. Some thought of it as a carer support, others thought of it as a social support. There was a lot of lack of awareness in the entirety of the health service. And finally, the medical management. So within this rural health service, as with lots of rural health services, there was a really close link with the general practitioners, and they would come into the health service and they would provide assistance on the wards while also helping in the community. They were doing surgeries, anesthetics, delivering babies. And so to them, the idea of also then having patients at home was considered quite challenging and probably a bit too hard. And so the major barrier in HITH in our rural area that we found was lack of awareness, whether that was from policies or just the actual HITH itself. Next slide, please, Ifta. We had a really close look at our carers and specifically the impact that HITH had on carers. We found that those who lived alone, that was their biggest barrier as far as actually getting a carer. A lot of these people had social help in the community from neighbours and things like that, but didn't consider them as a potential carer if they were to be admitted to hospital in the home. And so the biggest barrier within our older rural community was actually those living alone, because then they wouldn't qualify for HITH. Next slide, please, Ifta. Next, I'm going to chat to you about the benefits of HITH for older people in Australia. Next slide, please, Ifta. So what we learned was that what was already known was that it was really effective in direct admissions. There was reduced length of stay, as we've previously discussed. Patients and carers had really high satisfaction, but nobody had actually talked to them since 1994, so we thought we'd better have a look at that. And the medical management, when it was done right, it was sensational. This was commonly seen when the GP was involved in the care, so there was that continuity of care, and when it worked really, really well. Next slide, please, Ifta. Then we looked at, okay, well, for our older rural population, what are the benefits? And again, those efficacies were also seen. So we had a quantitative element to our research where we looked at the length of stay and readmissions, and we found very similar results in rural areas as with the metropolitan areas. So we found that there was a reduced length of stay, reduced mortality, and also reduced readmissions, but I'm going to go through that in more detail later. We spoke to patients, carers, and health professionals, and all found really high satisfaction when they were able to get into the service. Patient demographics were definitely seen as a benefit, especially for our carers, and also our rural community were very independent, and so they actually saw age as a benefit when they were able to get into the service. And that rural element was also a huge benefit. They knew the health professionals knew them, and so there were less barriers to overcome when it came to being admitted. With that rural element was also a really high level of person-centered care. So they felt that because they lived in the area and their health professionals lived in the area, they were going to be more likely to receive a higher level of care. And as a result, their health professionals were able to be more flexible. And so they could actually obtain a higher level of quality of life when they were admitted to HITH than if they were in the hospital, because they had that opportunity for flexibility. Next slide, please, Ifta. When we talked to our carers, they told us that being retired was a huge benefit for being a HITH carer. So they said that because they weren't going to work, they didn't have to hop up early, get the kids to school, and do all of those things. That meant that being a carer was actually quite easy for them. It didn't really impact their day-to-day life because they were with their partner or with their friends anyway. And so it was actually a huge benefit being retired. And this was a new finding that we hadn't previously read anywhere in the literature because, as I've said, people 65 and over are usually excluded from HITH research. So this was a really key finding that really gave us a real showcase that, okay, 65 plus is a really great option for in-hospital in the home, even in our rural areas. Next slide, please, Ifta. We then wanted to be a bit more solutions focused. And so we asked them about the enablers. Next slide, please, Ifta. So these are the things that helped improve the process of HITH. So education, we're not surprised by that. The more people knew, the more they utilised, the better outcomes they achieved. Having medical support was really important. We see this really commonly in our metropolitan areas, but we weren't sure again about that rural element. Utilising the service, no surprise there, improved outcomes. The more we used it, the better our processes became, the more data we had, and the better outcomes we achieved. Those holistic assessments in metropolitan areas were fantastic. Those people who looked at people aged 65 and over and said, well, you may be 65, but that doesn't mean anything other than the fact that you're 65, and they holistically assess their patients. that again was very much an enabler to getting older people into HITH. And having support interventions available, whether that may be shower assistance, meals on wheels, something like that, was really, really helpful in supporting that admission. Next slide, please, Ifta. So then we looked at our rural older people, and we found that, again, education was seen as something that they didn't have, but they knew would result in better outcomes in their HITH. Medical support, again, was inconsistent in rural areas, but was seen as a key element to improving the outcomes of their HITH patients. They recognised that they probably did have an unconscious bias towards older people, and so facilitating holistic admissions, again, and assessments would further support that. And they realised that there was a lack of support services. Given they were in a rural area, there actually weren't many support services available to their community. And so that made them start thinking, okay, well, what can we provide from our hospital that would then support those admissions to mirror the supports that are provided in hospital? And finally, they said, there's nothing out there that tells us what to do. There's no research. We're not really considered in policy. And so, if rural people and older rural people were included in research, that would really help to guide us. We could learn from each other and learn what works and what doesn't. And so then next slide, please, Ifta. When we looked at our carers, the things that helped them be the best carer they could be and have a really great outcome was that opportunity for empowerment. Our carers told us that they felt empowered being a carer. Their opinions were valued by health professionals, and they perceived themselves to be considered as part of the treatment team, not as an add-on. And this made a really big difference. So they took their roles really seriously. Their opinions were very highly valued. And they said that their past occupations actually were very helpful in being a HITH carer. And previously, when I've mentioned this, it's been assumed that they must be nurses or doctors or carers in a previous life. I'm talking about farmers. One of my carers was a sheep farmer, and he said being a carer was very much the same. It's just critical thinking. It's not that different. We had people who worked in hospitality that said, oh, it's just about prioritization. I've done this before. And so it gave them that opportunity to have meaning in their life again and have purpose in their day to day, which again, just further emphasized that empowerment that was achieved when they were able to be a HITH carer. And so this was the first time that we'd seen that HITH caring actually benefited the carers and not just the patients, further understanding why they were so satisfied being a HITH carer. Alrighty, next slide, please, Ifta. I'm going to change tact a little bit, and now I'm going to talk to you about the different models of caring HITH, because this was really closely linked to what we found. So in my research, I found that there's 3 models of HITH that have been reported in Australia. I would like to preface that. These are the ones that have been reported. So if you are sitting there going, none of these are my model of care, that is a little prompt to you. You need to do some research and publish it then, so that then I can read about that as well, okay? So the first model was the medical model. Now, you can see here that medical management is held by the admitting hospital. So those are the people who decide what medications you're going on, when you're being admitted, where you're being admitted, when you're going home. The admitting hospital also provides the doctor, and that doctor will either go into the patient's home or communicate with the patient through telehealth. And the admitting hospital also provides the nurse that does go into the patient's home. So this was the most commonly reported in the literature with really great outcomes. But in the rural element, there's barriers that they have to overcome if they were to use this model. There is intermittent phone coverage in rural areas. So, for example, in my rural area that I worked with, within 5 kilometres of the health service, there was no phone service. So telehealth was not an option for them, meaning that this model may not have been effective. Further, there's reduced practitioner availability in rural areas, which we all know. Therefore, they don't have the practitioners there to go into the patient's home. So this model would not be effective. And there's not the services available to support any of these different elements. There's not the services available to support people even getting home. And so a model like this would actually be very limiting in a rural area, hence why it hasn't been reported, and I have not encountered it at this time, which is disappointing given that the medical model also showed the greatest outcomes for patients, further challenging our rural areas. Next slide, please, Ifta. I apologise. I clicked next slide on this. We're going to go to the next slide again, Ifta. Yep, I apologise. That was my fault. Thank you very much. Next, we looked at the nursing model. So this was one of the most common models. And this is one that if you work in a rural area, this is the one that will probably reign true to you. So the admitting hospital, again, holds that medical management. They provide a doctor or a GP, but it is very unlikely that that doctor or GP is going to the patient's home. More than likely, the patient is travelling to the hospital to see the doctor for their weekly appointments. Maybe they're going to the GP or the GP is coming to them, but more than likely, the GP and the doctor and you, as the patient, are communicating over the phone. The admitting hospital does provide the nurse that goes into the home, but the real key difference here is that the doctor is really not going into the home. Next slide, please, Ifta. While this is a really great solution in rural areas, it does also have some complications. Again, that phone coverage is a problem. If there is not internet and phone service, it makes it very challenging to allow a collaborative HITH experience. That practitioner availability can be really challenging. It's challenging enough to get one person to be a part of a HITH admission, let alone to get two communicating effectively and having the time to do that is really challenging. It also adds burden to the carers, having to drive that patient to the hospital for their weekly reviews. And also in the case that something goes wrong, they need to be able to drive them there. So it means that they're tied to that patient a lot more. The patients need to travel. For those that have VAC dressings and who experience pain hopping in and out of cars, it's further adding to that burden for the patient as well and increasing the chance of poor pain management as a result. And finally, again, it still comes back to that service availability. If there's no one available in the area to assist with showers, it's just adding a lot of pressure to the nurses and it's also adding a lot of burden to the patient. Next slide, please, Ifta. The final model was the brokerage model, and this one was really interesting. And we were really excited originally when we found out about it, but don't get too excited yet. So this is commonly used in rural areas, and especially with specialty hospitals like the Royal Children's Hospital. So they use this model quite a bit. And so the admitting hospital is usually a tertiary health service or a major metropolitan health service. And so they hold the medical management, meaning that the patient is admitted to this tertiary health service. But the patient is able to go home because the medical management is held by the general practitioner who also provides the nurse to go in and see the patient. So again, the nurse and the GP work closely together and then they communicate with the admitting hospital to ensure the treatment plan is effective and going to plan. This means that rather than patients having to stay in the city to receive acute treatment, they can go home, which may be 200, 300 kilometres away. So the benefit there is huge. Next slide, Ifta. The problem with this model in rural areas, there's a few. So again, service availability. So if they need a nurse to be coming out twice a day, but the health service doesn't have that capability, it's not going to work. Again, there is that carer burden. The patient has to be driven to go and see that GP or driven back to go and see the medical team at the admitting hospital. So this could be several hours both ways to get that medical review. Again, further exacerbated if there is a deterioration of the patient that they're not actually admitted to the local health service, they would need to drive to that tertiary health service. Again, as we've discussed, further adding that burden with patient travel. Again, the challenges with the practitioner availability. Is there actually a GP or doctor in the area that has the capability and the capacity to take on another patient? And finally, there's challenges with the funding availability. So how this works is the admitting hospital provides a fee for service to the rural HITH health centre, which sounds really great. But the challenge here is that the numbers in the data for the funding reimbursement is not reflected for the rural health service. It's reflected for the metropolitan health service, which means that when the Victorian government looks at the rural health service, they may say, you're only actually admitting 4 patients a year. That's not very sustainable. When in fact, they could be caring for 200 patients a year. They just use the brokerage model. So there's problems there, which mean that health services are looking that they're not performing well, when in fact they are. They're just using this model, which isn't currently reflected in the reporting data. Next slide, please, Ifta. So let's now look at the models of care with the patient outcomes. So what we knew from the literature was that the metropolitan health services are primarily using that medical model. Next slide, please, Ifta. And we know the outcomes of our rural health services from my one study. So we know that there mostly is a decrease in length of stay. We know that we're not really sure about treatment failure when we compare the two. We know that across the board, there is high patient satisfaction. Across the board, there is high carer satisfaction. Across the board, decreased mortality, and across the board, decreased readmissions. Next slide, please, Ifta. But if we now look at that specific to each of the models, we actually know that we only know about the rural HITH model in the nursing and the brokerage model. Okay, so we know that those outcomes are only linked to the nursing model and the brokerage model, which means that we don't actually have any data for direct admissions using the brokerage model, given that they would need to be admitted through a metropolitan service, meaning that the brokerage model is most likely resulting in poorer patient outcomes, which is further disheartening for our rural health services who are primarily using this. Okay, so further adding those challenges. Next slide, please, Ifta. Thank you very much. So currently within HITH research, what we know is very much a black and white view. We know, does HITH work? Yes. Does HITH policy work? Yes. Is there funding that's available and sustainable? Yes. Are services able to plan and initiate HITH? Yes. This is a very black and white view though. Next slide, please, Ifta. If research starts asking, why does it work? How does it work? When does it work? We're actually going to get a lot clearer picture about what's going on. And I am going to push research here again, because really we need to be doing more research on the broader concepts of what people are and who people are. We know that at a broad sense, length of stay works, definitely. But if we look at the different models of care, the different patients that are being admitted, where they're being admitted, who's providing the care, suddenly you'll come up with lots of question marks, as you've seen throughout this presentation. So while I don't have all of the answers for you, I apologize. A lot of the answers are there. They're in research. And so if you're sitting at a health service going, I know the answer to these questions, I just don't know how to do the research, Nat, flick me an email. I'm more than happy to help you get your research out there. Because the problem is that we're writing policies, but we don't have research to back up what we need to be providing. And so then that policy directly interprets the funding that's available, which again doesn't count for our older rural communities and many other communities, which makes it so challenging for health services when they're trying to plan what does HITH in the future look like all by themselves. Next slide, please, Ifta. Thank you so much for having me on here to chat. I hope this has been helpful. I am here to answer any questions. You have my email there. Please don't hesitate to flick me an email, whatever it may be. I'm interested in research. I've got a poster I would like to turn into research. I'm absolutely here to help and guide you. The more HITH research we have, the better. And if you're interested in my research, there's a QR code then that links to my research gate. So all the research that I've presented today is there. Anything that's currently under review and about to be published will also be posted there. Thanks for your time.
Thank you so much, Natalie, for the incredible presentation, as well as congratulations on the work you've done so far. First of all, just reminding everyone to please, if you're not a member already, scan my QR code as well as Natalie's QR code to become a member of the HITH Society so we can support these amazing type of work and presentation and the ongoing grand rounds. Now, if you have questions, please put them in the chat and then we'll get them to be read out and get Natalie to answer. So we got one already. I'm really curious about what has been found in terms of how the medical care under a rural brokered model, noting that MPS services are generally not rebatable for admitted patients, including HITH admitted patients, block payment or fee for service. So quite a long question. It's mainly in regards to how I'm assuming the payment is during brokered.
Yeah, this is a really interesting point because it's not published about, it's only discussed between health services, and most health services don't publish their funding, so it's quite limited. The health service that I worked with said that it was just a fee for service, and then they were reimbursed for the fee, they were reimbursed for the HITH admission themselves. So on paper, they were the ones providing the care, and so then they were financially reimbursed for that. However, the health service were then just given a lump sum of whether it be $100 a day as a complete example. Please don't quote me on that. Does that answer your question? I apologize. There's not a lot of information out there to answer it more specifically than that. But please feel free to email me if I have totally gone off base.
No, perfect. Thank you, Nat. And we'll get Phil to reply if he wants to end the clarification. Next one is, how do we know what's the worst outcome for people admitted to HIT from hospitals? Aren't related to them potentially being higher acuity?
This is a really great question. So, when I looked at the quantitative data, and some research has done the same, they actually have the DRG, so the primary admission code. So, whether the person is admitted with cellulitis or major heart failure or a NOF or whatever it may be, to allow comparisons across the board. So, in the data that I've presented today for our rural communities, where I've said there was a decreased length of stay, I've matched the patients there based on what they were admitted for with their age, their gender, to make sure that they are as matched as possible. There is the limitation, though, that we don't know how many complications are there if it's not recorded in the data. Definitely more research can be done here, and definitely the acuity of patients would be something that would be really helpful. In Victoria, where this research was conducted, all patients are acutely admitted, and none of my patients were from ICU. They were all general ward patients. So I can be confident that I'm comparing ward patients with ward patients. However, definitely more research can be done. So I think I know what your next research will be. Zeta, you've got more research to do.
Excellent. Another one about demographic of the patients is, have you included residents in aged care homes versus community?
Yes, some of my patients were in aged care and some were in the community, but they were quite limited. So there wasn't any significant differences in the outcomes of my patients in aged care versus in the community. However, Justin, if you would like to do research on this, I'm very eager because I feel that HITH is very much underutilized in the aged care setting. And I think that there's massive opportunities, especially in rural areas when we've got registered nurses, they're ready. I think that there's another model of care that could really roll out here. But from what I saw, yeah, both were included and the outcomes were quite similar.
Thank you. There is a comment in regards to very encouraging finding regarding the care experience and teasing out the why is a positive experience for them. So saying well done. A question which I'll raise in regards to care experience was showing how the retired are enjoying it. They're happy with it. They're providing good care. Did we explore carers who are not even related or know the person who's being treated under HIF to utilize them in our community?
I would have loved to, but there were just none in my population, IFTA. There's not really that service wasn't available in my rural area. There was no option for that. The two people that I spoke to were cohabitating already. So they were already living with the person prior to becoming their HITH carer, which again would make a big difference. They already know the person, they're comfortable, they know them inside out. But IFTA, you and me, more research, the different carer elements, absolutely. We did look at the gender of the patients and we found that men were obviously a lot more pragmatic and our women were very much more of a nurturing approach. I don't like to gender stereotype, but that is what the data told us. But otherwise, yeah, the why, I'm very interested in it. So when I looked at the why did the carers have a good experience, I looked at the different aspects of their identities, which gave me a great idea. But there's hundreds of ways to look at it. And yes, Julie, if you'd like to look at it more closely, let me know. I'm very interested.
Natalie, you're going to love the next question, which are you aware of the Department of Health in Victoria are currently reviewing the hospital at home policy, including HITH, and are you providing input?
I am. You will see the next comment is from Karen, who's also on there. Very much so. Yeah, the Department of Health have been very much a part of the journey, listening to my findings as I go, which has been really helpful. And yeah, very much a part of that project and very much looking forward to seeing what we achieve together.
So until we get to more questions in the chat, which I'm sure are coming, question for me, Natalie. You
Of
have now
course.
completed this project. What is your next project that you're going to look at?
Oh, that's the question. There's too many options at this moment in time. I am a big fan of the aged care. So I was serious early when I said if anyone wants to do research, please let me know. I would probably like to do more of an Australia-wide look at our older communities. I would like to also incorporate that aged care element, especially with the increased funding for resident inreach. I think there's a huge crossover between resident inreach and hospital in the home, and I'd just like to see what the differences are and how they could potentially work together. That's where I'm at next. But that is the question. So if you have an idea of a project and you have no interest in doing it, but you know it's a good project, let me know. I'm open to suggestions at this point in time, Ifta.
Thank you, Natalie. Yes, residential enrich is definitely an interesting point, and I would recommend actually starting with doing a review of each state as well as the differences within the state itself. We even have
Definitely.
issues with the definition of enrich, as in different states. Sometimes it's called outreach,
Oh no.
which is quite interesting. So you're going to have a fun time with that
Oh, the joys
topic.
of terminology. I do have a question for the crowd. Could I just get a hand raise if you are from a rural area, whether that's a rural health service or you just identify as a rural person? I'm just really curious how many people in the room are from that rural space, given that in the literature, at the moment, it's just me, and that just really doesn't make sense to me. Oh, I love it. So many. Fabulous. Well, now I know who you all are. So definitely reach out to me if you want to do rural research. I'm really, really keen. We'll let regional count. We know that you're really in that catchment. We know that you go beyond. That's fine. Thanks, guys. Greatly appreciated.
It is
Back
quite
to you,
interesting to
Ifta.
no, thank you, Natalie. So we have, what have we got now? For people hoping to understand the research project but have minimal experience, can we seek a mentor within the society? James, that is a fantastic question, and please do reach out. So you can email either Natalie directly or you can email the society. So you can email myself or you can email the admin at hithsociety.org.au, and we can link you with the right person, which most likely will be Natalie, but we will definitely link you. We
Definitely.
then have a comment from Felicia in regards to came late to the meeting, but keen to understand your perspective on primary care involved with HITH. From a sustainability perspective, I feel GP and nurse practitioner engagement in primary care is important. What is your comment?
I totally agree. And I think, especially in our rural areas, definitely. I think our practitioners could be the missing element in those rural areas. I've spoken to some rural emergency nurses who say that they have patients who sit there and wait all night to be admitted to HITH because there's no doctor on, but the nurse practitioner is sitting right there and could admit them to HITH and they're a perfect HITH candidate. I think changing the policy, Karen, to include nurse practitioners with admitting rights could be really huge for HITH, especially in rural areas. The only concern that I have is that in my research, I wasn't able to chat to GPs. So if you're a GP who delivers HITH, please talk to me. Because from what I understand, I think that there is limited capacity of rural GPs. I think that they have huge catchments, huge patient loads, and I don't know whether they have the capacity to take on a HITH admission, but I would love to know because if they do, that could be incredibly beneficial, especially for that continuity of care. It could be fantastic. But at a high level answer, super important. Completely agree. Yes.
Perfect.
Good question, Felice.
So while we're going to wait for a bit more question, the next question to you, Natalie, what we're going to look at is, of course, we have HITH in different perspective across Australia as well as New Zealand. Right now, do you think it's important to have the same terminology that we're all using and standardize it?
Yes. Look, standardized terminology. When I first started doing my HITH research, that was the first thing that came across my desk. And I went, this is so silly. Surely it's not that hard. It is huge. If you try to do a systematic review on HITH, you can't just look up HITH. You can't even just Google HITH. The different admission pathways, there's different names for that. People call it admitted, transferred. We really need to get some common terminology. And within my research, lack of awareness was the major barrier for our rural communities. And so I think that really contributes to when different health professionals talk about it, we use different terminology. And so we don't know we're talking about the same thing or something different. And already within the medical field, we know that as health professionals, we talk a lot of jargon. And so that makes it even harder for patients to understand. So I think at least as health professionals, we can all be on the same page. That will then give us a really great understanding to help educate patients as well. So high level answer, yes, common terminology would be great.
Perfect. Thank you so much, Natalie. Again, for those which are still with us, please become a HITH Society member if you're not, as well as utilize the QR code of Natalie to follow her or email her. And yeah, do have a beautiful rest of your day and beautiful January, and welcome the new year with an amazing presentation. Thank you so much,
Thanks.
Natalie.
No worries. Thanks, guys. See ya.